If you've ever felt a pinch or an ache right in the front of your hip when you're running uphill or lifting up that knee, climbing upstairs, or even just standing up after a seated position, stop assuming that what you have is a tight hip flexor. Sometimes just stretching it repeatedly can just irritate it more and more. It can be the problem is just irritating that very tissue that is already overloaded. I'm Dr. Joe with Performance and Recovery, and today we're going to look at when a runner comes into our clinic with that pain in the front of the hip and what you can kind of do about it. The iliopsoas, or better known as the hip flexor right here, is one of the primary muscle groups that helps bring the leg forward when running, but also contributes to control and stability around the hip and the pelvis. When that muscle or tendon becomes overloaded, runners may experience pain deep in the front of the hip or even into that groin area. They may notice different kinds of discomforts, such as running uphill when they're doing their speed workouts, those high knee movements, climbing stairs, getting in or out of the vehicle, or even sitting with that hip bent for extended periods of time. Some people might also notice that kind of clicking noise or snapping in the front of the hip. But here's the important thing. Pain in this region does not automatically mean that the psoas is dealing with a tendinopathy. The hip joint, which contains the labrum, the adductor muscles, the rectus femoris tendon, and even types of bone stress injury can produce a pain in a similar area. And that is why we do not just diagnose anterior hip pain with just one of these social media tests, okay? So runners develop these types of injuries often because of the demands of their training exercise, and they exceed the capacity of the actual tissue. So maybe you recently increased your mileage. Maybe you added more hills or more speed, or even just more trail running where it's uneven grounds. Or maybe your hip flexors themselves are being asked to compensate for limited hip extension, poor pelvic control, or even reduced strength elsewhere in the kinetic chain. And that painful tissue is that warning light going off. Our job here is to determine what is causing that warning light to turn on. Simply resting may temporarily reduce the symptoms, but if the tendon never really rebuilds in its capacity, then that discomfort may return as soon as the running volume increases again. So there's a couple of different aspects and assessments that we like to check out, and here's a couple things you can do at home to see if you have some flaws or faults. So one thing we can do is what's called resisted hip flexion. So whether it's on the ground or on a bench or something, we can go up and we can try to drive ourselves through this, keeping our hips and knees up. And we're going to see if this recreates some of the pain in the hip, if there's clicking, if there's popping. Does one side look noticeably weaker than the other? Can the person hold the position without leaning backwards or rotating their pelvis? And a painful or weak test can often be useful information for this. It doesn't necessarily mean these are the problems. It becomes one piece of the complete evaluation. So I showed you some stuff where it can be proper. Now, if we look at things where it's improper, if I'm just sitting down here, we can kind of go here, right, as a nice proper one. Or is it something where it's like more difficult to pull that back and we try to get that knee or leg out instead of just nice and straight forward as we pull? Or is it something where we're twisting into it or away from it? These are different faults in that kind of test. Again, from here, we can go pulling, right? nice and steady. And as we pull, does the knee kind of flare out? Does it cause some of that pain? Do we want to pull ourselves into it, or we're going to back away from it? Those are kind of some of the common faults that we may see for that test. Another common test that we've really been enjoying is the step up and over kind of test. So what we want to see as we step up and pretend to go over a object, or like on this bench, we're trying to see how good the stability is in the hips, the knees, and the ankles. So that shows you a little bit more stable motion, but there could be ones where we try to drive that opposite leg in, and then this hip collapses, our body kind of compensates as we come down. There's cases where we can't hold ourselves up, and that knee itself collapses down. We have ones where as we go into that single leg, this ankle has the issues and kind of collapse and pronates into it, or if it's a other kind of issue where we land hard. I'm watching not just for the painful hip, but I'm watching the entire kinetic chain. I'm watching to see if the pelvis remains level. I'm watching if the trunk lean, is it excessive? Does the standing knee collapse inward or outward? Or does even the foot lose stability in itself? A few other aspects when we're looking at more so runners and trail runners is, can the runner lift the opposite knee without pinching this front of that hip, especially if someone comes in for this type of pain? Or can they even control the descent, or does it just drop quickly onto the floor, making that like thud noise? So running is essentially a series of repeated single leg motions. And any compensation that appears during these single leg, one-legged movements, they're repeated 1,000 times during a single run. Now, another thing that we often can access and assess through is if someone brings in a video of them running. So we kind of see what kind of running mechanics they have. Are they doing proper like hip extension? Can it comfortably extend behind the body? And if they lack the proper hip extension, they may be compensating for arching the low back, rotating their pelvis, or increasing that through the front of the hip and into the knee, putting more stress on the quadricep. And really, depending on the runner, we may also evaluate the cadence, the stride length, and how far the foot lands in front of the body. Is it something where it's really tight? Is it feel like you're reaching out and having more compensation throughout the back, hip, and so forth? So we're not really trying to force every step with every runner into one running style. As someone with shorter legs in comparison to someone with taller legs, each of their cadences and stride length is going to be very different. But we're looking for a modifiable factor that may be increasing the stress on the irritated tissue. In this case, we're really talking about a lot about that iliopsoas and hip flexor. Here at Performance and Recovery Clinic, we evaluate the patient and try to come up with a treatment plan that depends on what the evaluation finds. So first, we determine whether the painful structure is actually the hip flexor tendon, another muscle or tendon, the hip joint itself, or something else that needs further imaging or medical evaluation. When the evaluation confirms a chronic tendon or muscle tendon problem or fascial connective tissue issue, then that usually calls for the shockwave therapy. So the focused shockwave therapy is able to provide a mechanical stimulus to the injured area and support the remodeling process using acoustic waves. So there's no drugs, there's no surgery, and patients can often feel an effectiveness, whether it be directly in that same session or after a few sessions. It usually helps speed up that connective tissue healing very rapidly. However, that being said, shockwave is not automatically the answer for every painful like hip injury. The exact diagnosis and anatomy matter. We also may use chiropractic care, joint mobilization, and manual therapy when a mobility restriction is contributing to the runner's compensation. But passive treatment alone doesn't prepare a tendon for running. The long-term plan also has to do with improving the capacity. So that may involve progressive loading of the hip flexors, improving trunk and pelvic control, and strengthening the surrounding musculature, and gradually reintroducing running volume, hills, and speed. So whether that's something with driving up with kettlebells, some resistance bands, or something with like an exercise ball, we can use a couple aspects of the exercises to help you build up that progressive loading so that you can return to doing what you love. So that program should match the tissue involved and the movement deficit we identified and demands of that athlete's sport, whether that is just running, skimo, trail running, and so forth. So if pain or pinching in the front of the hip keeps returning every time you go for a run, stretching harder may not solve the problem. Schedule an evaluation with Performance and Recovery Clinic located here in the Roaring Fork Valley. We will evaluate the painful tissue, examine how your hip, pelvis, knee, and foot work together, and build a recovery plan around what your body actually needs. Don't just treat where it hurts. Find out why it hurts. Dr. Joe, hope to see you guys soon. Take care.